Good morning and good afternoon to anyone joining us from the East Coast. Thank you for joining us today. My name is Marisol Aviña, and I am the Director of Public Affairs at the California Endowment. It is my great pleasure to welcome all of you to today's policy webinar, Tracking the Diversity of the Health Workforce, Implications for Improving Diversity and Equity at the State, Regional, and Institutional levels. This is the second and final webinar of this series on a report supported by the California Endowment and produced in partnership with the George Washington Fitzhugh-Mullen Institute for Health Workforce Equity, titled The Race and Ethnicity of the California Health Workforce. The first part of the series covered the findings in detail, but if you missed it, do not worry. We will have a brief recap of some of the findings on today's webinar. As a health foundation, the California Endowment has invested over the years on efforts to reform and transform the health system. Our vision is that of an equity-focused system that advances racial equity, and workforce is key. For a state as diverse as California, it is critical to have a workforce that reflects the rich racial, ethnic, gender, sexual orientation, socioeconomic, and cultural diversity of our communities. We had a very rich conversation during the first webinar and are excited to continue it and to focus more on the policy implications of the findings with the amazing panel that we have today. A couple of logistics before we get started. We encourage all of you to engage in the conversation by posting your questions in the chat, as we will have an opportunity during the program for questions and answers from the audience. Also, we will be sending the recording of the webinar and the slides to everyone that registered. And then thirdly, I just want to note that TCE's policy webinars are intended to be nonpartisan and non-lobbying informational sessions. All right, so now on to the program. It is my pleasure to introduce our moderator for today, Dr. Hector Flores, who is Chairman of Family Medicine at White Memorial Medical Center and co-director of the Center's Family Medicine Residency Program. He has co-founded and also serves as medical director of Family Care Specialist Medical Group. With more than 35 years of experience in medical education, Dr. Flores is a national leader in cultural competency curriculum development and implementation, and has received several awards for his efforts to reduce entry barriers and ensure the success of underrepresented students in the medical professions. Dr. Flores served on the California Future Health Workforce Commission, and he also just recently concluded a very successful tenure on our board of directors at the California Endowment. And we appreciate you for your service, Dr. Flores. All right, over to you.
Thank you so much, Marisol. It's a real pleasure to join all of you today, and I want to thank our audience for joining us today as well. Yeah, it's a real pleasure to have worked with the California Future Health Workforce Commission. And for those of you who have had a chance to read it, or if you haven't, just a quick overview is that we focused on, our goals were to ensure health equity across the state of California, to provide accessible and affordable high quality services to all, and transform healthcare delivery to address social needs. So our charge was to identify the workforce needs to accomplish those lofty goals. And we decided to break up our work into three areas. One was around primary care and public health and the workforce required to do that, to accomplish a better system of care. Number two was addressing the behavioral health needs of our state and substance use disorder treatment. And then the third work group and category was the healthy aging and care of the older patient in California. And in each of these instances, we identified team-based care, everyone working at top of license, at top of training if they're not a licensed individual, and really focusing on a new workforce of frontline professionals and paraprofessionals that we will need to accomplish the work of the future. In part one, as Marisol mentioned, we on May 17th, the report was highlighted in terms of its components, and we're going to hear a little bit of it today with our keynote speaker. And that report is the first time that we've looked at 21 different health professions in California and looked at the diversity and representation, which I think will teach us a lot about the strategies we need to accomplish our future, which is a diverse population that is also reflected in the workforce that serves them. So it's my pleasure to introduce our keynote speaker, and I'll also introduce our panel members. so that they can actually hit the ground running as we get into our discussion today. First, it's the honor to introduce Toshe Oyemi, who is the director of the Flexner Beyond Flexner Alliance, based at George Washington University at the Mullen Institute, which produced this report that we're going to hear about. Toshe has extensive experience in research, teaching, and practice experience in interprofessional education, equitable health workforce, and development, and community-driven interventions in population health. So he was critical to the success of this report being together. He provided technical assistance and support to the authors of the project. So a really pleasure to hear from him in a second. Our panelists today are starting with Elizabeth Lansberg, who was appointed director of the Department of Healthcare Access and Information here in California. We call it HCI. She was appointed by Governor Gavin Newsom in December of 2020. This is a brand new department, and I think she'll share a little bit about that today. Previously, Elizabeth was Deputy Director of the Department of Managed Healthcare here in California, which is the organization that oversees all the HMOs in California and holds them accountable for the services they're required to provide. She oversaw the help center that actually dealt directly with consumers and providers with any concerns. Prior to joining the Department of Managed Healthcare, Elizabeth was Director of the Policy and Advocacy for the Western Center on Law and Poverty. So you can see that advocacy, care for the vulnerable populations, and representing their needs is very much in her heart. Because of her position as Director of HCI, Elizabeth also is a member of the California Workforce and Education and Training Council, which she'll share some thoughts about today. Our second panelist is a dear friend, Dr. Catherine Nation, who is a physician, and she is the Vice President for Health Sciences in the University of California, in the University of California Health Division. And she works directly with the Office of the President of the UC system. Dr. Nation has extensive knowledge in undergraduate and graduate medical education, and is specifically an advocate for diversity in medical school admissions. Many years ago, she and I had a chance to work on a UC medical student diversity task force, and I really saw her championing the cause of equity across all levels of education. She also has expertise in health professions workforce issues and the academic support and academic careers of a diverse population. In 2008, she was appointed as commissioner of the predecessor to the Workforce and Education and Training Council, which was called the California Healthcare Workforce Policy Commission. And today she continues to serve as part of the new California Workforce and Education and Training Council. And our third speaker, last but not least, is another dear friend, Jeff Oxendine, who is founder and president of the Health Careers Connections, based out of UC Berkeley. And he's also an associate dean of public health at the University of California at Berkeley. Jeff is an expert leader and champion for health workforce diversity. He's single-handedly led a lot of great organizations, including the California Health Professions Diversity Consortium, which actually is sharing experiences that we'll be talking about today. And he was the co-project director for our work in the California Future Health Workforce Commission. So without further ado, I'll ask you to help me enjoy and welcoming our speakers today, and having Toshe Oyemi start us off with a brief overview of the first meeting we had and the report itself. Toshe?
Yes, thank you, Dr. Flores, and good morning, everybody, and good afternoon to the folks in the East. Dr. Flores, I really do appreciate the kind introduction, and I really am grateful to the California Endowment and the rest of our partners and panelists who have pulled together an excellent two-part series that I'm privileged to speak a little bit about. I would like to go ahead and start by having the screen shared with the with the first page of the report. As was mentioned on the front end, what we had done was taken a close look at the race and ethnicity of the California health workforce. In the last month's session, we had an opportunity to share some of the findings of that report. And I'll have an opportunity to really quickly highlight some of the recap of what was shared. But before doing so, I'd like to, if you go to the next slide, I would like to just prepare just a couple of acknowledgements. The findings of this report really can be credited to our outstanding research team at the Mullen Institute at George Washington University, including our excellent researchers, Colleen Boguski and Janae Farrell, Professor Ed Salzberg, and Doctors Aaron Brantley and Maria Portella, all part of a broader team that had really worked incredibly hard on pulling the findings together. And of course, once again, I would like to thank the California Endowment as well as the Macy Foundation for the support of this report. It is important for us to recognize that though our institute at GW has really been spotlighting the urgency around the issue of workforce diversity, the solutions and the strategies that we want to see will be driven by the community leaders and the policymakers and stakeholders in the state of California. So exploring these strategies and solutions, it really is the main focus for today. And having the panelists, an interprofessional panel of experts who work in these spaces and are change makers is going to be critical for us to take the next step. Next slide. This is just a brief overview of the Health Workforce Diversity Tracker. This tracker can be found on the Mullen Institute website along with the full California report. Next slide. And you'll see in the report a little bit more in depth of what some of the findings were, both around the health workforce in California, as well as the pipeline itself. And when we're talking about the pipeline, we really are looking at the role of academic health centers in as the key producers and trainers of our workforce in California. You'll see listed here some of the major sections, and the report itself is actually also laced with some of the key findings. Next slide. So really just to reiterate the problem, I think that there is the big picture problem, which I think is not a controversial thing to really put out front. I don't think it's terribly provocative for us to really recognize the fact that there actually is a problem. And that problem is that we really do know that our healthcare workforce, it's a key leverage point towards promoting equity, towards achieving equity. And we have really lagged behind, specifically in some areas and categories and communities. We really do see diversity as being really one of several factors for our pipeline and for the healthcare workforce. Just one of several, which includes geographic distribution of providers, where it is that providers are practicing once they have completed training, where they're training, what type of investment the state is making in primary care, and the training environment itself when our student learners are actually in these different programs in medical schools, in nursing schools, public health schools, et cetera, across California, both in the state and also nationally. But it really is a key one, diversity, that can be addressed to improve access, opportunity, and health in California. So this really has been our approach and been our philosophy at the Mullen Institute, that this is a really key point that we feel that we have the capacity and the partners to be able to address. And we do want to ensure that this will be an opportunity to talk about that in the context specific to California as we continue to spotlight some of the findings both today and then, of course, into the future as well. Next slide. The slide here is highlighting some findings from the California the Kaiser Family Foundation, really just speaking to the nature and the magnitude of the problem. What we know is that people of color and other underserved and underrepresented groups, they really do face longstanding disparities in health. As I mentioned, because of the fact that we train close to 1 million graduates in the health workforce across the country every year, what they really do have in common, the common denominator, frankly, is that they are going through this academic health center. They're touching the missions of they're touching the missions of the clinical missions, the research missions, and the service missions of each of these different institutions. Next slide. Which really does bring to the bigger issue of diverse composition being a health equity issue. And I think we've seen that the research that we've compiled is that by increasing the health workforce diversity, we would see an increase in improvement in access to care, specifically by high needs populations. We would see an improvement in health outcomes and an overall reduction in health disparities and an improvement. It's also an economic improvement and economic investment in the state of California. And towards the end of this session, we will talk a little bit about some of the potential strategies to address the diverse composition or lack thereof that we currently see in the state of California and elsewhere. Next slide. As I mentioned, I will direct you to the report to take a closer look at some of the findings that we've seen as part of this study. But I did want to go ahead and list out some of the major highlights. We are seeing that just barely over half of California's school-age population are Hispanic, but are really poorly represented in specific professions, and school psychologists are one example of that. We see examples of this across professions and across racial ethnicity groups constantly, all across the state. We're also seeing that there is performance disparity across different programs within the state of California, including dental graduates, which are listed there. Asian Americans are underrepresented in every health profession training program we looked at other than social workers. And part of the interesting finding of this is actually the ability to disaggregate some of that data by ethnicity, which is an additional concern that I'm hoping that our panelists will be able to touch on a little bit. Private schools, they tend to have higher diversity index for Hispanic graduates. And part of the reason for that is because they are compared to a lower denominator, which is also explained in the report itself. And one of the other highlights that I did just want to mention is that Black and Hispanic students are really underrepresented across just about every educational program that we took a look at. There are areas in which we have seen success. There are areas in which there have been some strides made, and I think that those provide really important learning opportunities for us to discuss. Next slide. Now, recapping the earlier session and really moving into some of what was heard and what we want to now move forward with, here's a list of a few of those things, right? I think one of the major themes that definitely emerged was that solutions really need to be decentralized, but also aligned. There was an understanding that regional efforts are needed because of the complexity, the size, the diversity of the state of California. We also see that I think there's important recognition that diversity is broad. When we talk about diversity, it's not simply racial and ethnic diversity, though that is the focus of this specific report. But diversity is broad, and the idea of intersectional identities is an important consideration for any type of solutions that we look to introduce, which also require diverse strategies in order to address some of those complexities. We have an opportunity to really leverage pipeline pathways early on, as some of the panelists from the last session really spoke about. Part of that is greater investment and inclusion of strategies that do include the K through 12 pipeline, and not simply intervening too late into the pipeline when students who maybe have inordinate access to education and to different opportunities, training opportunities, even opportunities such as clinical shadowing and some of the other expectations going into health professions programs. For many of them, it might be too late if we don't address some of these early on. So there is a partnership opportunity with maybe less orthodox partners that are in other spaces of education and elsewhere. We also want to talk about addressing power differentials and acculturation, looking at the subpopulations that may be overrepresented in the population, but actually underrepresented in health professions. And I think a common example of that is looking at at ways that we're able to disaggregate, for instance, the Hispanic population, Hispanic workforce. Same thing with Asian American pipeline and workforce. Another common finding is in the disproportion of domestic Black Americans, domestic-born Black Americans versus folks who were born outside of the country, and the disparity in the outcomes and opportunities that exist there. So those are a few of the different things that I think we heard. And then, of course, a series of different roadblocks and barriers that we can address across different professions. Interprofessional problems really require interprofessional solutions. And I think that one of the other underlying themes that really did come out of that first session is that more data is, quite frankly, needed on the public health workforce. The greater workforce, of course, but public health in particular, as we know, the transdisciplinary nature of public health and the fact that it does cover very many different spaces, yet there's a lot of difficulty in being able to sort of define very specifically what the public health workforce actually is. So there's an opportunity there as well. And then I lastly want to pivot over, next slide. I lastly want to pivot over into what some of the future could look like and what some of the potential strategies that we might want to discuss are. Obviously, learning about successful strategies from some high performers. As I mentioned before, we do know that there are institutions, not just in California, but across the country, that have made substantial strides in identifying where their gaps are in their communities and in their spaces, and being able to actually address those in ways that have worked. Now, context matters. So being able to actually find what is relevant from that context is important. But one way of being able to do that is actually considering learning collaboratives, right? So given the fact that these strides, these changes are not just a testament to administrators, but administrators, to faculty, to students themselves, and to the community writ large, means that there might be an opportunity to really convene some of these different institutions and representatives from these different ecosystems to actually figure out what works, what might work in one part of California that's been working in another, what might be working in one part of the country that might work in a specific part of California. Additionally, we do want to point to considering initiatives that really do target underrepresented populations, and of course monitoring trends and comparing across institutions, professions that are adjusted for diversity of the population. Again, given the complexity of the state of California, but being able to actually establish baselines is going to be the first part for any sustainable solution. Next slide. And this will be my last slide before I hand it back over to Dr. Flores. Some of the strategies that we have discussed, in addition to the learning collaboratives and some of the ways that we might leverage successful initiatives in some places, it's not simply enough to know. I think that part of this is also being able to actually now apply what some of the knowledge and learning has been from other institutions and other communities. And there needs to be commitment to act. I think that many of the community stakeholders, community-based organizations, as well as policymakers do have the power and the influence to actually make sure that there is an accountability mechanism in place, so that this is not simply a recognition of an issue, but also an expectation that something will actually come from it. Publishing data to support advocates and change agents is another strategy, which this came from some of the earlier discussions that I'd heard from stakeholders, in that there are several community-based organizations that do want to address the greater issue of health workforce diversity or lack thereof, and they have the interest in doing so, and they maybe have the manpower to do so, and they have the community assets to do so, but there is often a need for resources, for greater partnerships, or for policy support. So that is an additional strategy to keep in mind. Collecting new data based on emissions in California is another way for us to be able to take a look at how some sustainable interventions can actually be made if there are more transparent and more granular interventions across different training programs and institutions in the state, to be able to create a little bit of a better database for tracking and monitoring and managing some of these strategies. And then, of course, really assessing the totality of the ecosystem, because what we're seeing around health workforce diversity, again, does not happen simply in a vacuum. It isn't simply an issue of trying to address counting numbers, but there also needs to be a recognition that the ecosystem within an institution, within a university, within an academic health center, within a nursing training program or a dental training program, et cetera, that does influence student success. And you'll see that across institutions and across professions, in the fact that acceptance rates, matriculation rates, and graduation rates, they're not necessarily commensurate, right? Which means that there is something that's happening within these institutions themselves that might be inhibiting or aiding success for students representing these underrepresented communities. And then also the ecosystem outside of the institution itself. Where are there other opportunities outside of specifically healthcare and of education for academic health centers and for the broader policymakers and stakeholders to get involved and to partner that can address what some of these different barriers to our diverse workforce are. So I'd like to, I'll end there, and I will hand it back to Dr. Flores. I do appreciate you allowing me to give a little bit of a recap, as well as starting to share some of what I think the thinking has been around creating a greater strategy for addressing this issue.
Thank you so much, Toshe. That's a wonderful presentation. I do have a question. I love the concept of these learning collaboratives because they lead to action and accountability. You also touched on addressing the social determinants of academic success for underrepresented minority students. Could you comment maybe on some of the innovation you're seeing across the country and maybe touch on those areas as well?
Absolutely. So as part of our, within the Mullen Institute, we've conducted an evidence review on what some of these different strategies are that can actually address different barriers. We came up with about just under a dozen different strategy domains that we've seen that are effective across different professions and across different areas. Pipeline programs are, of course, a really effective way of addressing this, and I think that's well known. But some different levels of innovation around how pipeline programs can actually be implemented is where I think that there might be some greater opportunity. And I think an example of this might be it's one thing simply to allow resources to be leveraged for the establishment of pipeline programs, but the actual development and the curriculum that's in place is just as important. So, for instance, rather than simply having a program that allows for rising seniors to be able to enter into a 3-month program or a 6-month or a summer program on their way into the undergraduate space. One of the things that could be done, one of the things that we've seen done is universities have effectively partnered with local public school systems and local student unions, right, to actually create a little bit more of an incubator early on. They're able to tap into identify students early on. There's a level of relationship building that's able to exist there. Something else that is actually that's another strategy that really could be tied in with pipeline programs is development of mentorship, right? The idea of including mentorships and role modeling specifically as part of pipeline programs and not as this separate siloed type of initiative. These things really do go hand in hand. So for instance, if you have students who are underrepresented in pharmacy, and they're now stepping foot into their pharmacy school for the first time as 18-year-olds, it really doesn't mean as much if they're not seeing people who can actually help them navigate it. There's something to be said about being able to offer specific assistance in helping access some of these different barriers and structures that are in place. Mentorship does that. There's role modeling in place that actually allows for support of career direction. And of course, we all know that there's an impact in being able to have that level of visualization of people who look like you and who have had similar shared experiences or come from similar cultural backgrounds. That's another really important piece. And I'll quickly just add a couple of other potential innovations. I think that one that maybe goes a little bit underlooked or overlooked, and I think it needs to, there should be a little bit more attention paid to, is really the role of financial support, right? Like what is it that federal funding can do? We have the health careers opportunity programs, the HCOPs, which I know are really effective. What more can we be doing outside of simply HCOP and these centers of excellence? Are there opportunities for really reviewing what the loan and scholarship mechanisms are that are in place for students of color? Are there opportunities for career ladders, right? And how can we adjust that into our intervention building? So some of the innovations that I think we've seen across the country have been able to implement some of these different pieces to varying effect. But I would encourage that one of the things that we talk about and look at is how all these things can happen in tandem to create broader agendas rather than really granular interventions, because it is going to require a little bit more systems thinking.
Yeah, thank you so much, Toshe. That's a great perspective and a perfect segue to our panelists. So I'm going to invite Elizabeth Lansberg to kick us off with kind of a general question of maybe describing what your organization is doing to address health equity and workforce, and maybe some of your overall goals in that area. And I see a couple of questions in the chat about the governor's proposals for investment in workforce. So maybe you can comment on that as well.
Good morning. Thank you so much, Dr. Flores, and thank you to the California Endowment for their support for many decades of workforce diversity, and to GW for their critical work. So yes, I'm the director of HCI, the Department of Healthcare Access and Information. We have long had workforce programs such as the Song Brown program, loan repayment and scholarship programs, all of which are designed to increase health workforce diversity. So our goals with our workforce programs are to increase the racial and linguistic diversity of California's health workforce, trying to do that at every level, from peer support specialists to doctors and psychiatrists. Our programs are all also designed to support professionals serving medically underserved areas. Those could be rural or urban, but we're measuring what areas need additional medical resources, and then always trying to make sure that we're building the cadre of Medi-Cal providers. So these goals are embedded in all of our workforce programs, from pipeline and career exploration to support of residency programs. We're working to encourage underrepresented populations to pursue health careers. I think Toya Shea talked about the importance of that. Incentivizing health professionals to work in underserved communities, and promoting equity in the way health professionals are trained and services are delivered to communities. So again, we've always supported training programs and individuals, but this is something a little newer that we're trying to look at. What are the curricula? What are the approaches of those training programs? Are they explicitly talking about cultural humility, talking about addressing unconscious bias, and taking an anti-racist and health equity focused approach? HCI does prioritize funding for our loan repayment and scholarship programs to individuals from underserved communities and those with experience working with underserved populations who are willing to practice in those communities. So all of our financial incentive programs do have service obligations to work in those communities. So just a couple of examples. HCI launched our Health Professions Pathway program in May, just last month, which prioritizes funding to organizations who focus on creating health workforce pipeline programs, internships, fellowships for individuals who are underrepresented in healthcare. We know this is an important step to make sure students of color are exposed to the possibility of health professions, but it's not just about the exposure and financial support, but also mentorship, as has been talked about this morning. We're also incorporating equity measures into our programs to focus on increasing the language diversity of the health professions we support. So we have redesigned some of our loan repayment applications to make sure that we're prioritizing applicants with fluency in Medi-Cal threshold languages and experience in practicing in underserved communities or growing up in underserved communities. So we know we have more work to do, and look to engagement and discussions like this one to most effectively to talk together about how we can most effectively support diversity in health workforce. And just to bring it back to the presentation, all of this is about increasing the effectiveness of health services, and we know that increasing the diversity will lead to better outcomes. I also want to talk a little bit about how, and Toya Shea touched on this, about how diversity and support of that can mean different things for different professions. So HCI has programs supporting training of certified nurse assistants, CNAs, for the first time this year. So that's already a workforce that is very racially diverse. It's made up mostly of women of color. So our diversity goals with CNAs are going to be different than workforce goals for diversity goals for psychiatrists. So for CNAs, we're asking what support are being provided to this workforce. Are they getting sufficient wages? What career advancement opportunities are they being provided? In our upcoming workforce programs, we're looking more to stipends and scholarships than loan repayment, recognizing the racial wealth gap. But we also know that financial support is not enough. So again, mentorship is important, looking at other barriers. For example, we have a lot of initiatives to develop the behavioral health workforce. One of our stakeholders, I was in a listening session yesterday, and one of our stakeholders pointed out to me, for example, that we have many students of color graduating from the CSU system, the California State University system, with majors in psychology, but they can't afford to do the clinical hours required to work in the field. So let's find those folks, let's pay them for their work. I don't think we're in a position at the state where we shouldn't be expecting people to do volunteer work. We should be paying them for their clinical hours and making sure they have the support to actually join our behavioral health workforce. We need them. I know there was a question specifically about the governor's proposal. So there is a $1.7 billion investment proposed in this year's budget that was jointly developed by the California Health and Human Services Agency and the Labor Welfare Development Agency, and there is significant funding. So it's around social workers, it's around psychiatric professions. It has a very exciting community health worker proposal and promotores proposal, which is new for the state to really invest in community health workers and promotores to be part of a team-based approach, which will be very meaningful in increasing diversity. And then there are specific dollars set aside both for HCI and for the labor agency to focus on increasing linguistic diversity of the workforce. And we know that's critical, again, to increasing outcomes is to increase linguistic diversity. So some of the approaches that we're looking at there, again, is to make sure our loan repayment and scholarship programs are focused on folks who are multilingual. We are, in terms of those we're supporting, we think it's important to look at both multilingual people born in the United States as well as immigrants and refugees, many of whom may have had training in their home country. So we're looking at everything, again, from our loan repayment and scholarship programs, but also supporting programs like Welcome Back Centers and IET, Integrated Education and Training Programs, where we can help folks, again, who may have some health training in their home country, help acclimate them, make sure they have the English skills, the orientation to California and the United States healthcare system, and hopefully fast track them to licensure. So there's much more that I could talk about, but those are some initial thoughts.
Thank you, Elizabeth. And since it's kind of a burning question that was asked about specifically the English learners, what really that question speaks to from Edgar is the broader issue that many community-based organizations have, is that they don't necessarily know where to access these dollars. They're hearing about dollars, but they don't know. How might you suggest that community-based organizations start to look at this and look for opportunities?
Thank you so much, Dr. Flores. And it's something that HCI is focusing on a lot more, is trying to make sure that we're getting information out. So I really do encourage all of you to go to our website, hcaa.ca.gov, and I'll put some information in the chat if I can. We are having webinars. We've had several webinars about our workforce programs. In June, we're going to continue. In May, we're going to continue to do those. We are really aggressively trying to get these dollars out. And so please do check our website. Please sign up for our webinars. There are programs for you as community-based organizations to benefit from. For your employees, we're hearing about the workforce crisis, about community-based organizations needing to retain their staff. So we did just open a new cycle. Loan repayment is an important retention strategy. So please, we want you to know about our services, and we're trying to get the word out as much as we can. Thank you.
Thank you, Elizabeth. Next to Dr. Catherine Nation, same question is, what are the University of California's goals around diversity? And maybe you can share some of the current initiatives that are underway.
No, thank you so much, Dr. Flores, and for the kind words at the start. I think, as you mentioned, I've had the privilege and opportunity to really work directly, actively, endlessly across my close to 30-year career within the university on issues of diversity, equity, and inclusion for the health professions. And those are for reasons that everyone here today will understand. And I also really want to acknowledge the California Endowment for their steady partnership with UC, with others, in support of the California Future Health Workforce Commission, where I had the privilege to be the senior advisor for our former UC President Emerita, Janet Napolitano. So just a lot of focus, and I'm delighted to see the level of state investment for these, and to be a partner, Elizabeth, to you and to HCI as we look to all move this forward. So I'll mention two, and this goes to earlier remarks about the roles and the responsibilities, I think, particularly of public institutions, and in being a resource for students, keeping a focus on public service and public benefit and the needs of the state. As I think back, and Dr. Flores, you reflected, on a group 20 years ago that we assembled within the University of California to specifically look at the precipitous decline in medical student diversity that we had seen at that time, and we really focused on best practices that we understood nationally. We put those together, and I would say that those were strategic domains. I also call them core elements as we look to develop our UC Prime programs. These are programs in medical education, launched in about the year 2000, now with upwards of 500 graduates. We had a challenge with state support, as most on this call may know, but are grateful finally to see that investment. For our UC Prime programs, which I believe are a model for the health professions. They are adaptable locally. What these core elements include are a clear identity of the medically underserved community to be served, a clear strategy for student recruitment, a clear link in the admissions process, the curricular focus, again, on communities to be served, the targeted clinical placements for students, and then critically, as has been mentioned, faculty mentorship. And these core elements across our Prime programs, with now the opportunity to develop, several more, have us now at a total of nearly 400 Prime students enrolled, with growth that is planned. 68 to 79% underrepresented in medicine, contributing substantially over this 2-decade-long journey to 4 of UC medical schools being recently ranked in the most diverse in the nation, and that includes the recognition of the long work of our HBCU colleagues. So I think the key is engagement. It is accountability. It is metrics and measurement. And then the second that I'll mention, and I'll be mindful of time, spans the health professions. Director Lansberg mentioned the fact that all professions don't start at the same place. I know this clearly. The UC system is really the largest health professions instructional program of its type in the nation. In addition to our 6 medical schools, we operate schools in nursing, in public health, in dentistry, in optometry, in veterinary medicine, and in public health. And so 2 years ago, I formed a leadership task force with designees from each of our deans. This culminated in the production of a system-wide report that went to our UC president, Michael Drake, and to our Board of Regents. The report contains very specific recommendations for enhancing the diversity, equity, and inclusion of our health profession students, our residents, and our faculty. We are well on our way, and we'll have an intense focus in the years ahead on the implementation of our progress, again, with specific metrics and accountability expected beginning with each school and with each profession. So I'll stop there with that. Thank you.
Thank you, Catherine. And that UC Diversity Task Force that you and I worked on took on the initiative to look at the holistic assessment of applicants to medical school, because we were dealing with Proposition 209. And I'm proud to see that my alma mater, UC Davis, is now one of the top ranked schools in terms of medical student diversity, above and beyond the Prime program. And can you share a little bit of that journey, Catherine, how the university adopted holistic admissions processes? And
I think I can, and I thank you for the comment on this task force, on the formation of this task force, being within the context of the passage of Proposition 209, where prior to the passage of that proposition, UC medical schools had a long distance, but were among the more diverse nationally. What we saw then really was a precipitous decline over the years that led to the formation of this task force. And we included the leadership of our medical school admission deans as part of that work. We went on and we reflected really on best practices. We reflected on constraints and responsibilities and a level of accountability. And from that really came, again, the core elements for our UC Prime programs, that those were developed at that time and as a consequence of that task force. And I think the key is steady focus, right? I can, look back and remember the steps and the years and the times and the climate across 20 years of leadership work that needs to continue into the focus into the future. And what we said about Prime at that time is it was a strategy for expanding enrollment opportunities for California students. There's interesting data from the AAMC that shows that across the states, California leads the nation in the retention of medical students for future practice. We lead the nation in the retention of medical residents. We're at the bottom of the nation nearly in educational opportunities per capita, but we sought to expand medical education opportunities by growing our class size, but doing this in a social mission aligned way, 20 years ago. And again, this was clarity of focus in terms of the underserved community to be served. We have a rural prime program. We have a new Black African-American prime program. From that date and time, our last year's class, we have 105 African-American Black students. Our total UIM diversity across our system is now at 39%. Prime is a contributor, but it has been really, I think, the steady focus on public accountability, on student outreach, on admissions, and holistic review is really central to all of this. Our UC medical schools have used holistic review for a very, very long time. We are steadily working to advance those discussions across other health professions where it may have been a lesser practice, because we do know that it's a best practice.
Fantastic. Thank you so much, Catherine. And let me move then to Jeff Oxendine, who's going to talk about pipeline programs and other enrichment activities. Jeff?
Thank you, Hector, and I appreciate the opportunity the endowment provided to be here today. As Hector mentioned in my introduction, I wear many different hats. I'm working at the statewide level, at the regional institutional levels, and working directly with individual students. And all of those are focused on the goal of building the next generation of diverse health leaders and professionals for California and our communities. And as Dr. Nation just mentioned, providing opportunity for more Californians to be that workforce. We have the rich diversity in our state, in our communities of talented, passionate, place-committed students who want to be those leaders and professionals. And it's our imperative that we work together to build that ecosystem that Toyeshe mentioned, to enable them to be in those roles and to meet our health workforce needs of our employers. Given the crisis that we have right now in health workforce in all areas of the workforce, and the imperative for diversity that Toyeshe and others have laid out. And we have to work across all those levels in a more coordinated way to be able to make this happen. And it's really, we have to work across the continuum. I mean, it's not just in enhancing K through 12 that we've already talked about the criticalness of that, but also getting those college students into health professions schools in the way that Dr. Nation mentioned and the great programs that they developed. And then it's HCI supporting people all across the continuum, including the loan repayment and scholarships and all of the things that are happening. So we've got the moment in the state where we have the California Future Health Workforce Commission recommendations that really lay out a roadmap of how to do it. And it's tremendous to see the commitment that the state and the philanthropy employers have made to implement those and invest in those recommendations. We have the new programs that HCI is rolling out, and the programs that UC is expanding. So really it's now about It's about implementation. For decades, we've been working on getting the coming up with the solutions and getting the resources. And now I think now we have the resources. So now we've got to really work together to effectively implement them to meet the intended results. At the state level, the things that I'm involved with the California Health Professions Consortium, we are trying to connect the dots across all the different programs. The consortium has the top K through 16 health pipeline programs in the state, from the Doctors Academy to Faces for the Future to One Future Coachella Valley and others. And we're connecting those programs to each other to share best practices. As was talked about earlier, we have a learning collaborative called the Experienced Pipeline Collaborative, where these top programs from around the state are coming together on a regular basis and sharing what they're doing to be able to support students across all levels to get into health professions. I think we need to share that out our work more broadly from those programs, because these programs have decades of experience doing all the things that Toyeshe mentioned. I also think at the state level, we recommended with the California Future Health Workforce Commission that with the Health Professions Career Opportunity Program implementation that HCI is working on, that there be a learning collaborative of those programs that are funded as well in a state office, and creating a learning collaborative to share those kind of best practices. So hopefully those are things that can be part of this implementation that we're working on. On a statewide level, with Health Career Connection, the nonprofit that I run, we are recruiting thousands of students from throughout the state who are undergraduate student and recent graduate students to get paid health internships in public health, in behavioral health, in primary care, in long-term care, all the areas that were prioritized by the commission. And so we're partnering with employers and with health plans, like the Blue Shield of California is funding us to support students all across the state from all the most underserved communities to have behavioral health internships and learn about how to take care of their behavioral health, and connecting them into graduate schools and to employers. LA Care Health Plan is supporting students to work on a large scale in the LA area in the safety net. These are college students from the LA area working in the safety net. And then we're connecting them to the pipeline that LA Care has already created about medical school capacity increases, scholarships, loan repayment, those kinds of things. So I'm working with Hospital Association of Southern California and to be able to have a large scale number of our students to be able to work in their hospitals, and really changing the culture and building that diversity. So I think it's working at the state level, but the rubber meets the road at the regional level, that we're such a large, diverse state with so many different regional needs in terms of employer health workforce needs, and in terms of programs and educational pathways, that we as a state need to support more regional infrastructure. There are a lot of these, so I would say, fledgling health pathway collaboratives that have come together that are connecting with the health profession schools that Dr. Nation leads, and connecting with other employers in their area. But I think if we can work to invest in more infrastructure at the regional level to connect the dots from K through 16 to employment to practicing, coming back and practicing in the areas, I think that's going to be really important. And then supporting those pipeline programs to be able to be at scale. A lot of these programs are really strong. They have best practices already, but the endowment and the Wellness Foundation and others have kind of kept them going over the years. So hopefully with the HCI investment that's being made, and hopefully in other ways, we can invest more in sort of these robust regional collaboratives, both to have pipeline programs be successful, as well as have the dots connected in ecosystems at the regional level. And finally, to have those regional systems linked to the state priorities, to being able to really, because we have to have regional solutions, but they have to be aligned with the statewide priorities and programs and investments that are being made. And I think that we're well on our way to being able to do that, but we have to do that in an intentional way. Finally, I think we need to remember that the public health workforce, as Toyeshe say, isn't well documented what the needs are. But we really have a public health workforce crisis. COVID exacerbated the years of underinvestment in public health infrastructure and workforce, and isolated a lot of the public health leadership, had people resign from the field. It was already an aging workforce. So across all these pipeline programs, even though we don't have the documentation that we do in medicine and nursing and other licensed professions, we've got to get in touch with what to do to build that future public health workforce in the governmental sector and other ways to do that. And Health Career Connection is doing that through our work. We focus on the public health work for at UC Berkeley School of Public Health. Really is investing in that work, but we need a more robust support from the state in order to build that future public health workforce and have all the clinicians also, not going into public health directly, but with our population health and value-based payment perspective, needing to be able to make sure everyone's trained in the public health and social determinants of health lens. Thank you.
Thank you, Jeff, and I appreciate you calling out the role of the health plans, because they're the ultimate beneficiaries of all the work that all of you are doing. And it's great to see that LA Care, Kaiser for sure, Inland Empire, Blue Shield is investing in the finished product, which is how do we support physicians in underserved areas so that we just don't take for granted that they will be successful because we helped them along the way. So thanks for calling that out. Regarding pipelines, Jeff, you are the master plumber who's figured out how to limit the leaks in the pipeline. Certainly Health Career Connection is a great program. The consortium is another. And recently we've seen a collaborative started by the California community colleges through their foundation, California Medicine. Mm-hmm. Could you talk a little bit about how they're adding something really important, an important element to the work that you do?
Yeah, California Medicine is really adding something that's been a sort of a missing piece of the puzzle, which is to really focus on having community college students have much better defined pathways into medical school. We know that the community colleges have the rich diversity. They're in all the different communities that we have, but there's a lot of barriers to those students being able to make it through all the hurdles to getting into medical school. So as I mentioned, it's so critical that we work at the regional level to be able to support students, to connect the ecosystems in those areas. And so the California Medicine Scholars has created regional hubs, and this is supported by HCI, regional hubs in the Central Valley and in San Diego, in the Inland Empire. There may be one other that I'm blanking on, but they're creating these regional hubs so there can be really a focus on articulating the pathway and making the institutional changes to support the community college students to get through community college, transfer to a 4-year school in a really good position to get the requirements done for medical school, and with the kind of mentorship support that Toyoshi mentioned is so important, the academic support is so important, and then really have there be a well-defined pathway where the medical schools are reaching back and helping make sure that the 4-year schools and the community colleges, are preparing the students in a way that they can be qualified competitive applicants, and that they'll be able to get in to these schools. So it's a long pipeline. It's not a long piece of the pipeline, but it's a really important new addition to the state.
That's fantastic. Well, let me invite Toyoshi back to our panel, because the work that George Washington University and the Mullen Institute are doing is going to be critical. It's giving us the evidence, as Elizabeth mentioned, it's giving us the evidence to know how to fine-tune our diversity strategies based on the profession that we're talking about. And if there's ever a litmus test for all of us, is the diminishing number of African-American males. And I wonder what each of you thinks about how we should approach that. I love the idea of an African-American Prime program. I think that's a really great start, Catherine. But maybe each of you can comment about what you've learned and what we might then do in a concerted effort to address that. And we'll start with Toyoshi, with your work.
Yes, certainly. Actually answering this question is probably a little bit of a response to several of the things that I heard Director Lansberg and Director Oxendane, as well as Dr. Nation, mention. I think of 3 things that I really want to harness back specifically around that, because I think that many people are likely familiar with the really popular statistic about the fact that the Black males in medicine, it's still lagging at less than 3%, I think 2.7% nationally, still somewhere maybe even south of where it was about 40 years ago, or at least consistent with it. That's not progress, regardless. I mean, the status quo was certainly not progress. I think that needs to be recognized. And a couple of things came up that I actually think could be harnessed to address this issue and maybe some larger issues. One is actually a point that Dr. Nation had made around the role of having really strong HBCU colleagues. And I completely agree that the role of having not just HBCU partners, but also HSI partners, tribal college partners, it's key. But I think that there also we need to make sure that predominantly white institutions do not use that as an opportunity for a bit of a cop-out, right? Like there still needs to be accountability from all of these different institutions who have not been producing a diverse workforce across healthcare and frankly in other sectors as well. So there really is an opportunity there that I really do think that we need to acknowledge. And it's not simply the responsibility of the state schools, the private schools also have a responsibility there as well. So I think that that's one piece of it. That actually tacks in with the second thought I had, which I believe Jeff had mentioned around, I'm sorry, I think Dr. Nation had mentioned this around the PRIME program. And as you sort of explained that, and you talked about the idea of public accountability and some of the work that the PRIME program has really done around, admissions and holistic review. All those types of innovations are what I think actually set California apart, right? I think we look at California for those types of innovations, and I think that it's going to be important to consider how those admissions processes can continue to play into policy decision making and how community partners can actually be engaged. Because the idea that students of color are not in these spaces is largely false, right? It's a matter of whether or not there's intentionality around saying like, hey, we see a value, we see a healthcare value, an equity-based value in ensuring that access is equitable for those who have historically been disenfranchised from academic medicine and academic healthcare altogether. And I think that the community college university partnerships that Jeff laid out are one example of that. Community colleges are already in the communities of which we largely want to reach, and they play in a significant role, not just for the bridge into other undergraduate programs, into graduate studies, but in and of themselves, the community colleges that I've worked with in the past are far more in tune with what the needs are and what the barriers are of communities than the big flagship university often is. Those are major assets that we need to further invest in, and that we really should institutionalize these types of university community college partnerships. And I do know that there are some examples of that also happening in California. And then the last thing, and then I'll pass it on, is I really want to lift what Jeff had mentioned as far as the rubber meeting the road at the regional level. And I think that the idea of having, this is actually the first that I'd really heard about the California Health Professions Consortium. And I think about the fact that this is largely in and of itself, it's a bit of a learning collaborative right there. We have a de facto learning collaborative outside of simply recruitment. What is actually happening in these institutions that may not be creating a hospitable and equitable environment, not just for students of color, but also for faculty of color, administrators of color, because all of those pieces are part of this ecosystem, this contribution that an academic health center should be making towards not simply diversifying, but ensuring that those students aren't meeting hostile environments, ensuring that the faculty, staff, and administrators are being well supported. As we start to address some of those things, that greater aspect of what we call social mission, right? Like the idea of not just diversity, but inclusion, about the practices that are taking place, about the distribution of our trainees and of the students. I think that all of those levers working in concert can actually help address some of these lagging numbers and racial disparities in healthcare professions.
Thank you, Toyshe. Catherine or Jeff, on the issue of the African-American male as a kind of a litmus test of the work we need to do.
Yeah, no, I'm happy to lead off, and again, an area of focus, I think, of our UC Medical School admissions deans over a period of 2 decades, and part of the concept and core elements of our UC Prime programs. We launched these programs with intention, with focus, with consultation with our medical school leaders. Unfortunately, it was at the time of the California's Great Recession, right? So as we launched state general fund support that does not cover the cost of attendance. Our prime students, our UC medical students, graduate with considerable debt. And this is something we're going to have to revisit in terms of the level of public investment for health professions students, because the debt is a deterrent. I took many questions, through the years about, why we did not have a UC Prime program focused on any number of different underserved communities. And this was not because of a lack of recognition of need. It's because there is an inherent cost to medical student education that is just based on the requirement for supervision as our students learn. So we're thrilled that the budget recently included, not only the previously unfunded support for our prime enrollments, a top recommendation of the commission, it also provided the University of California with funding to launch 2 new programs, each of which will ultimately enroll 48 students. One of these programs will split its enrollments. This is for Black and African American students. Those programs will be at UC Riverside and at UC Irvine with new incoming students. I understand they've hit enrollment targets. The second new prime program will also split its enrollments, 12 students per year, 48 total, focused on Native American students, but with the same core elements. And so this will add, I think, substantially to the steady gains that we have made in diversity across groups, but with steady gains also for Black and African American students. I think this will be building. And then the last comment I'll make is that there is an opportunity, not just California Medicine, for intersegmental public higher education partnerships. That's just so important. And I'm proud that the 4 regional hubs are UC sites. We intend to link these up with our prime and other programs and pathway programs, as we know these are some of our best practices.
Thank you, Catherine. Jeff?
Yeah, just to build on what's been discussed already, it's an ecosystem that has to be built, aligned at all different levels. And my colleagues and Dr. Jocelyn Garrick and others in the Alameda Health Pipeline Partnership, another great local pipeline program and collaborative learning community. They actually did focus groups with African American men and boys in Alameda County, and they found that the biggest barriers started at the K through 12 level, where they were a lot of the pipeline programs were right after school. The boys wanted to play sports, and they couldn't play sports and be in the pipeline program. That they wanted to do, they needed to make money, and so they had to work instead of being in the pipeline program, in which they didn't get paid. They wanted to do things that were more hands-on, and they perceived that many of the health careers were not necessarily hands-on, and that they may be more female-oriented, was these perceptions that they got from the focus groups. And so I think we need to look at redesigning, how we engage with not only African-American men, but the same thing would apply to Latinx and other men, to be getting them into the pipeline programs and how they perceive different health careers. And then we've got to help them succeed academically. I do think we need to focus a lot on people that are already in college. We've got people that have made it through and they're in college. And so how do we help them in college get the mentorship, the academic support, the internships, the connections to health profession school, intersegmentally, as Dr. Nation just mentioned. And then we have to change the admissions process, as we've already talked about, and the culture. With Health Career Connection, we have had lots of students, lots of African-American men get into medical school, only to find that the culture of medicine and the way that they're dealt with isn't very supportive to them to be able to be successful as well. So we have to sort of work intentionally in all levels. And as you said, Hector, I think if we do this for African-American men, it will benefit everyone. Everyone come through the pipeline.
Yeah, absolutely. Elizabeth, anything else to add from that perspective?
I don't have a lot to add, but I just really want to appreciate the question. And I think it's critical for us to look at the different needs of different populations, and not just to assume that there's a one size fits all approach. And so the pipeline is critical. I love hearing that Alameda was actually asking Black men and boys, what do you need? What about our programs didn't work for us? So the pipeline is critical, but then, as Mr. Oyami said, it's just critical that once folks actually get into the program, what are we doing to support them, to support the faculty, and looking at the curricula and how how it's being taught and what opportunities there are after. And then we're here to make sure people don't leave with a whole lot of student debt that they can't pay back.
Great, thank you. And we're almost at time, but I do have another question. And you touched on this, Elizabeth, about international medical graduates, internationally educated nurses, and other professions. We often worry that if we have an initiative to recruit them from other countries, we create a brain drain in those countries, and we don't want to do that. But on the other hand, we know that many of them are already here because their native countries don't have the same type of infrastructure like we do with Medicare, Medicaid, so that even if a doctor graduates in Mexico, for example, if they can't get into the lucrative jobs with commercial insurance, they can certainly be supported by a program like Medicare and Medicaid. They don't have that. So they're actually here already. And, you know, talking about these hubs and regional collaboratives, from the panel's perspective, we know that there's going to be stakeholders who will oppose. For example, I'm a member of the CMA, and they'll always step up and say, well, we don't want international medical graduates because we don't know the quality of their education, et cetera, when a lot of it is also protectionism, right? So what can we do through these collaboratives so that rather than vilifying the CMA or others, engaging them in coming up with a solution? Because the reality is our current production in the US is not going to keep up with the growth, especially of vulnerable populations. And HCI and the governor could be conveners of this kind of thinking. So let me start with you, Elizabeth, and then have the others weigh in as well.
Right, and we have started to have those conversations. HCI does work on the J1 visa program, which we took over from DHCS, and so that's an opportunity for 30 folks a year to come in. But I agree with you, Hector, it's less about trying to have some sort of a brain drain than really working with folks who are here and making sure that they have the opportunities. And so we understand that there may need to be some training, but let's be really specific and targeted in our approach. It's a huge opportunity to diversify linguistically and racially, and so we do want to work productively with folks. I think we're at a point in our workforce crisis where we can't reject any solution. We need to have a yes and approach, and we think that working with foreign trained medical professionals is a key piece to make sure they get. I mean, no one's talking about not having them go through some of the licensing requirements, but we cannot have them start from square one.
Yeah, thank you. And we're almost at time, but Catherine and Jeff and Toysha, I'll give you.
No, I'm smiling at Dr. Lansberg's yes, and I think those were words in front of a legislative committee years back as UC worked to pilot the UCLA International Medical Graduate Program. Right, we wanted a yes and we wanted a regular pathway. We created a pilot through which international medical graduates could come and be eligible for hands-on training as a pre-residency sort of a program. This is not a program that receives state support. Many of you are familiar with it. As I talk with family medicine directors across the country, they would like to see double the size. But it is 12 months. It is intended to enable the individuals, the physicians in this program to competitively match in family medicine. And year over year, I think has proven successful. So there are models. This is one that merits some look. It could be replicated in other places, but it is a common pathway. And when we took it, we sunsetted the pilot a few years later, and this was legislation co-sponsored by UC and the medical board, with not any opposition from the Assembly or the Senate or from anyone, just based upon the rigor and the quality and the outcomes. Absolutely.
And I had a chance to work on that with Dr. Patrick Dowling back in 2003, and we were lucky to get funding from Molina Healthcare. Mario Molina stepped up and funded the initial phase, and then Kaiser Permanente came up with a community benefit grant to sustain it. I'm going to do my best. Chuck, Todd, Jeff, and Toyoshe, you have 30 seconds each because we're at time. So
I just want to emphasize back to the importance. Dr. Nation mentioned, a model program that could be replicated. I go back to this: can we invest more in our state to expand and scale and replicate the proven programs that we do really have? One of the recommendations of the California Future Health Workforce Commission, a top 10 one that hasn't been implemented yet, and most of them have, is creating a program, a learning collaborative, and an investment vehicle to support model programs that have been proven over the years to work, to really help them be sustained, scale, have a greater impact, and have a learning collaborative to share best practices, public best practices. So I would want to advocate for having that recommendation pursued with maybe health plans, the state, others who could fund that type of recommendation. It could address the question you mentioned about African American men and what are the best practices. In the chat, we had Jessica Pitt sharing. She has an internship program for young men of color at the 9th grade level. And I know Jessica is an expert on doing this work. So we could really create the knowledge, and then we could help promulgate those best practices to get them implemented. So I think having some kind of a coordinating entity for pathway programs to help them be efficient, effective and at scale, and having the investment of resources in them, I think is important. I think it's a great time to do that.
Thank you, Jeff. And Tosha, you have the last word.
All I need is 15 seconds because there's not much more that I can say that my brilliant colleagues haven't already said. I just want to make the point, more of an urge to, in thinking through what type of inclusive solutions to these licensing requirements and what type of policy would come around that, is to ensure that we really are truly valuing and validating the experience and lived experiences, that expertise that comes with people who are coming from other countries to the United States to practice.
Fantastic. I want to thank you all for giving of your time for this panel today, and want to thank the endowment for supporting this. So Marisol, on to you.
Thank you so much, Dr. Flores, and thank you to our amazing panel, Toya Shea, Elizabeth, Jeff, and Catherine. Thank you so much for this very rich conversation. On behalf of the endowment, echo the appreciations. Thank you for sharing your time with us today and your partnership. You have definitely given us a lot to think about. And to our audience, we want to hear from you, and we hope that you will take a few minutes to provide your feedback on a survey that you will be receiving in the next day or so. It should be coming to your inbox, along with the recordings to both sessions. I know someone asked in the chat how to find part 1, so we will include both links in the thank you email that will be going out in the next day or so, along with the slide deck. And we will also include the website that Elizabeth mentioned on the HCI program. So you can find that information also on that email. So look out for it. Thank you again so much. This concludes our program. Have a wonderful day.